Hello and good afternoon, good evening, wherever you are in the world. Thank you for joining us on this hopefully very interesting conversation. And I'll straight away pull in some of the guests that I've got, and I'll quickly introduce Bruce, Professor Bruce Uhal from Michigan State. I'll let him tell us a little bit more about himself. And we've also got Dr. Neil Bodie, who is also from the USA. This time in San Francisco, is it, Neil?
Los Angeles.
Los Angeles.
West Coast.
West Coast. And so we'll probably start with you, Neil, because Bruce has been on before. So let's hear a little bit about yourself. Tell us a bit about what you do, what your interest is in COVID, and so on.
Sure. I've been involved in biotechnology for about 20 years now, and I've been studying one very esoteric part of immunology called antibody-dependent enhancement of infection. Started studying that with dengue in 2006. So I've got 14 years, and I have 38 years as an emergency and critical care veterinarian. So I witnessed firsthand the failure of the feline coronavirus vaccine due to this phenomenon. So cats that had been boosted with the FIP, as we call it, vaccine, actually got the disease earlier and got a more severe version of the disease. So I have a lot of concerns about coronavirus vaccines, and that's a lot of my background.
Wow. So topic for us to be getting into. And so, Bruce, if you don't mind introducing yourself again, tell us a little bit about yourself and your expertise, especially with regards to ACE2.
Well, hello, everybody. I'm a professor of physiology at Michigan State University, and for about 35 years, I've been studying lung injury. I was a biochemist by training, studying initially the pulmonary surfactant system. And then I got interested in lung injury and repair, and really stumbled upon the angiotensin system in the lung when I was briefly in a cardiology division in Chicago at University of Illinois at Chicago, when everyone was talking about angiotensin 2 locally in the heart. And I stole some of those ideas and wondered if something similar could be happening in the lung, and started looking at the role of angiotensin in lung injury and fibrogenesis. And that eventually led me about 15 years ago to start looking at ACE2 and the inhibitory arm of the angiotensin system. And we've been studying ACE2 and its product, angiotensin 1 to 7, the peptide, both of which are inhibitory against lung injury. And now with this pandemic and a virus that binds to ACE2, I've sort of unwittingly become an expert on viral entry into the lungs. And I've sort of taken some crash courses on virology to get up to speed to start to deal with these issues. So it's been a very interesting ride.
Well, yes, I can see that based on what was happening, which was unique. And for people who don't quite understand, the entry point for the virus into cells is through that ACE2 enzyme receptor complex that's on the cell. And so this is why Bruce would suddenly become such a critical part of the conversation. So with that in mind, I think the primary thing that we're focusing on today is we're going to be exploring a bit about the paper we've just published, Bruce, on the concept, the theory of autoimmunity. We're very happy, Neil, because you're the independent in this, to critique any points. We're sure that there are many things that we may have missed or things that need to be covered. And so we're very happy to hear your point. So just to summarize the principle, all that we have said is that at this stage, with over 300,000 people across the world dead, we have a virus that we don't understand the mechanism that it's doing all of the injuries. And all we have asked the question about is it possible that the virus is bound to some of the soluble ACE2, which is in the serum, and because it's bound to the virus and then taken up by a macrophage, which is a cell that processes these bacteria and viruses, is it possible that the body then creates antibodies against the virus and also ACE2. And that's simply the summary as to all we're saying. And the critical piece of the puzzle is that it's not just ACE2 that will be targeted, but it's also ACE, because there's a 42% homology between both enzymes. And if you had antibodies produced against both of those, my goodness, it would be one heck of an inflammatory response. So, Neil, any thoughts?
Yes, I've gotten a tremendous amount of feedback, both positive and negative, on LinkedIn. One of my more popular posts was that article, and it stimulated a lot of conversation. But a lot of things I've looked at is certainly the SARS-2 spike protein S1 goes through a lot of conformational changes in order to bind to ACE2. However, it also appears that ACE2 is going through some conformational changes. And that resulting complex is probably going to be recognized as foreign to the immune system. And there's a large number, Bruce, you pointed out the scleroderma, that, a lot of people have autoantibodies in scleroderma, but in a lot of connective tissue diseases, lupus and things like that, there's a very high percentage, almost 90%, that have autoantibodies to ACE2. So I do think, obviously, the differentiation between self and non-self can be broken down in autoimmune diseases. And we know that viral triggers, either molecular mimicry or other things, are a good reason why the immune system will go after a self-protein. So I think it's something that we need to look at very closely.
Can you just clarify? There is 90% of autoimmune diseases have ACE2 autoantibodies?
Yes, I posted that article on LinkedIn with someone who questioned your theory and said, I'm skeptical of it. And I said, really? You need to look at autoimmune diseases. My original background was in autoimmune diseases, and then I became fascinated by how viruses can use our immune system against us. And that's why I sort of transferred from autoimmune diseases into infectious diseases. But I have a strong background in autoimmune diseases, and the breakdown between self and non-self, viruses trigger that all the time. Guillain-Barré is a good example of that. And so, a lot of times people, we're getting still a lot of information because this is changing so quickly, but the viral titers seem to be the highest in the first week, but it's in the second and third week when people are in the ICU that they're getting a cytokine storm. That's not when the virus titers are the highest, but that's when the immune reaction is the strongest. And so I think that we really need to look at the theory that both of you have put forward, that it's probably the tip of the iceberg, and there's a lot more that probably is happening in these cases.
Any thoughts, Bruce?
Very good points, Neil, and I was struck by one comment you made about the conformational changes that occur in the spike protein and also in ACE2. And I've been struck by some of the writings and some of what seem to me to be assumptions in the literature, that one of which, for example, is that the soluble ACE2 that gets released from various cells maintains its enzymatic activity and or its ability to bind virus as tightly as the endogenous ACE2 that's stuck in the plasma membrane of various cells. We're going to be measuring those things very carefully in the future, and I can share some preliminary data with you. When we look at enzymatic activity, to our surprise, we have, for example, 4 different human lung epithelial cell lines, all of which express ACE2 to varying degrees, and all of which release immunoreactive soluble ACE2 into the culture medium above them, which we do serum free, so there's no contribution of serum components. And we've just found that the soluble ACE2 released by at least two of these cells does not appear to have any enzymatic activity. Whereas the ACE2 that's stuck in the cell membrane is enzymatically active, and the ACE2 that is, well, if you have recombinant human ACE2 that you can just buy, of course, that's enzymatically active. But so far, we haven't been able to find any enzymatic activity in the soluble ACE2 that's released by these cells, even though
So,
it
yeah.
contains, it contains a sequence that has the active site. So, we're not sure that the sort of common perception that the soluble ACE2 is still functional and acting to degrade angiotensin 2 and so on, whether or not that's really correct in all cases. And can it bind virus? I mean, I haven't seen any data really that can tell us the soluble ACE2 release from cells. I mean, certainly recombinant ACE2 that you can purchase binds, but whether that soluble, the conformational changes that you were referring to, Neil, may be very important and a lot more complex than we actually know yet.
Mm-hmm. So it's relevant because one of the other points that you had found was that the area on the enzyme that the virus binds to is not the active part anyway.
Not for the enzymatic activity, but then enzymes can do very strange things where it's something binding. I mean, hemoglobin is a good example. I mean, something binding to a distal part of the molecule through conformational changes affects the binding of oxygen or CO2 to other parts of the hemoglobin. So it's just conformational changes can do, even slight conformational changes can do some very strange things to binding or enzymatic activity.
Yes, yes. So, I mean, in terms of one of the things that had struck me very early on with regards to the people who were affected by the disease was the high level of people who have hypertension and cardiac disease. And that to me was a red flag because I couldn't understand why conditions where people were immunosuppressed, HIV is a good example, why would they not have such a high level of morbidity or mortality if this was purely infective? Any thoughts on that, Neil?
Yes, I mean, most of the comorbidities for any of the coronavirus, whether it be original SARS, MERS, or the new COVID-19, almost all those diseases are characterized by inflammation. So that's the key, is that inflammation is not necessarily your friend in this disease. For a lot of diseases, the immune system reacting and the subsequent inflammation helps clear the infection. In this case, I think it's hurting the host as much or more than the virus itself. That's what we've got to try to figure out. I know someone that has heart disease that was a high-risk person, and when he got COVID-19, he only had GI signs. He never had any respiratory signs. He never had a cytokine storm. So those factors are playing a tremendous part, and we just don't know. And again, as Bruce said, Bruce and I were talking earlier this week about how many papers talk about the downregulation of ACE2 in COVID-19. But no one's really worked out the molecular mechanism by which that happens. And a lot of times when you look at papers, they quote a paper, they quote another paper, and you keep going back and you get into sort of a circular argument, and you realize that they're just quoting each other. And no one really necessarily knows that answer. And I think this is extremely important. This is not a trivial point to try to understand this disease. What is exactly happening between the virus and ACE2? And how is that contributing to respiratory disease? As Bruce pointed out, what they're seeing is not exactly the same as acute respiratory distress syndrome. It's a different version of that. And again, we have to be careful about using past examples and applying it to this disease until we really understand this disease. And you get a lot of what I call fog of war. It's just you read papers and then 2 weeks later they're retracted. You have to be careful. So I'm just saying we have to look at the totality of everything that's being published. And of course, I take any paper, but especially a preprint, with a certain grain of salt.
Yeah, there's a question here that came from Rick about the claim behind people with blood group A having worse inflammatory responses. I don't think this paper has been published as yet, but I remember I saw it yesterday, and straight away I thought, wow, that does look interesting. And the only thing I can say on that point is that when I did a quick check, what it seemed as though is that anyone, or when you look across autoimmune diseases, type A blood group seems to have the highest percentages compared to the other blood groups. And so that was my thought. Maybe they have an intrinsic mechanism that could make them more prone to immune responses. Any thoughts on that from anyone?
Well, yeah. I mean, again, there's also, I mean, there was a paper that came out of preprint in China, and they looked statistically, and they did find that certain blood groups were, had worse severity of the disease. But there's also a difference just in sexes, age and sex. Males are more likely to get more severe COVID-19. Our mortality rates are certainly much higher in males, and older males, of course, that type of thing. But again, we don't know, and it's interesting because women tend to be more predisposed to getting autoimmune disease, but to a certain extent, their immune system may be more tolerant in certain situations. Pregnancy is an immunotolerant situation. So and estrogen also, Bruce, you can comment on this, the effect of estrogen on ACE2.
Well, to my knowledge, the estrogen is believed to be a negative regulator of ACE2 expression. This was one of the proposed mechanisms by which one might explain men having worse outcome and infected with COVID-19, the idea that they might have higher expression of ACE2 because of the effect of estrogen to suppress ACE2 expression. But I think that's an oversimplification of what is regulating infectivity. It's much more complex than simply the amount of ACE2 on a given cell or in a given organ. We know already that there are other factors besides the level of ACE2 that control the ability of viruses to get into the cells. Proteases, for example, required for the priming of the spike protein and so on.
Yes.
So I think that's really an oversimplification. And we see this many places, the notion that different the susceptibility or poor outcome of various populations can be explained by their level of ACE2 expression. I think that's a very severe oversimplification of the problem.
And so,
and I think Bruce has, I'm sorry, I think Bruce has an excellent point here, because I was looking at some of the animals that are susceptible to COVID-19. And for an example, rabbits, ACE2 binds apparently to the spike protein very well. But when I checked with some of my veterinary colleagues, rabbits appear to be resistant to COVID-19. So as Bruce said, you can't just be looking at the distribution of ACE2 in a species or organ and say this is going to be the tropism, or these are going to be the species that are going to be susceptible to ACE2. More complicated than that. There's other factors we don't understand.
Absolutely. And so would you say anything in the context of the genetic predisposition? So say, for instance, certainly in the USA and the UK and certain parts of Europe, there does seem to be some degree of racial preponderance among the ethnic minority groups. Would you think that is more environmental rather than genetic?
Well, that's the thing. You have to be very careful. I'm sorry, Bruce, I cut you off, but you have to be very careful because there's socioeconomic factors that also enter into it. Now, in Italy, they just published an article in the last couple of days looking at genetic predisposition within the Italian population. and they tried to adjust for race and that type of thing. And I think that that's what we need to be looking at, is what are the genetic factors that are independent of socioeconomic factors? And that's hard to sort out, but it's a combination of things. What's the access of people to healthcare? I have a tremendous concern about what COVID-19 is going to do in developing countries. You know, Somalia has 15 ICU beds four ICU beds per 12 million people, one per 4 million people. I mean, you know, how are they going to handle something like COVID-19? And a lot of the refugee camps, they're just trying to barely survive. They don't have masks, they don't have social distancing. And when people think this is an over there problem, it's like ripples in a large pond. You know, the outbreaks over there are going to come back and hit us with subsequent waves in the future. We need to be thinking about the whole world situation.
Absolutely, absolutely. Were you going to say something, Bruce?
Well, I was just going to add to the complexity of the situation the notion that ACE2 is glycosylated, and it's very likely that glycosylation is a very important determinant of viral binding. So there have appeared already many studies looking at just the level of ACE2 expression in various tissues, organs, for example, human organs, trying to explain why certain organs get affected better, more than others, for example. And many of them based on RNA, just mRNA alone. And of course, we know that protein levels don't always follow mRNAs. But in addition to that, there's also glycosylation of the ACE2, which is likely a very important factor. All factors that we really don't know very much about, but we need to get a handle on in order to understand what's happening in this disease. Yeah.
I'm just going to bring up a question from Kanan here. I don't know if anyone wants to take it on about the immune imbalance occur at the innate immunity level, and can we measure the imbalance or dysfunction to determine the severity? Say, for instance, interferon signatures. Quite a heavy question. Anybody want to try and take that on?
Well, you know, again, you can be looking at some of the assays that they have currently, like for TB, the T-spot, the cellular ELISA-based assays, the interferon release assays, and looking at T-cell immunity. Now, that may be active immunity and not innate immunity. And you have to look at, you know, where the innate immunity is being stimulated by coronavirus. But these are all things that need to be worked on, that some people are doing, but we need to really look at it. And looking at the molecular mechanisms and understanding that is going to be imperative for us having successful treatments.
Yeah. Another question from Rick. He's mentioning the blood group A again and its correlation with different patterns in the 4 respiratory epithelial cell types. Wow. Go ahead.
We have no information on that yet. That would be an interesting thing to look at, but simply not enough information yet to begin to answer that interesting question.
And I'm just doing a few questions here. So Chris has a question here. So this is quite a long one. The furin binding sequences in the S protein of the SARS-CoV virus, these may also become antigenic, leading to antibodies against the sodium channel proteins, which could therefore cause, I guess, some of the symptoms that we're seeing in COVID-19. Any thoughts on that?
It's
possible. Do you want to go first, Bruce? Sorry.
Go ahead, Neil.
No, I was going to say, why don't you go ahead first, and then I'll put input. I'm sorry.
Well, it's possible. I mean, ENaC, of course, involved in pulmonary edema clearance. So any compromise of ENaC function, and you'd likely get a edema response in the lungs. One thing that's interesting about COVID-19, though, in contrast to classical ARDS, in classical ARDS, which is a permeability edema, as opposed to cardiogenic pulmonary edema, which involves increased pulmonary capillary hydrostatic pressure. In classical ARDS, It's strictly a permeability edema, collapse of the alveolar capillary barrier, leading to first interstitial edema and then eventually alveolar flooding once the epithelial barrier collapses. Little of that is seen in COVID-19. There's surprisingly there's little alveolar flooding. It's believed to be primarily an interstitial edema, and surprisingly no decrease in compliance. In classical ARDS, there's a decrease in compliance due to surfactant being washed out of the alveolar surface area when the alveoli flood. Often in COVID-19, compliance is preserved, and there's little alveolar flooding. It's difficult to imagine mechanistically how that could happen. So there's still a lot we don't know. But ENaC, of course, being involved in edema clearance, if there's compromised ENaC function, then that would lead to pulmonary edema.
Absolutely. You were going to say something on the point.
I think this gets down to, we have to really examine the phenomenon of molecular mimicry, how viral proteins can cross-react with self-proteins. Our work shows that the vast majority of viruses where ADE has been documented also encode a FC binding protein, an FC receptor, if you might call it. And we found that in dengue, we found it in Zika, we found it in Ebola, Zaire in Sudan, we found it even in H1N1 pandemic influenza. And it's been noted already in mouse hepatitis virus, the coronavirus, that the spike protein also binds to antibodies. So in the process of testing spike protein, that also is going to trigger autoimmunity. And you're likely then to get into a vicious cycle where if you're, especially in a vaccine, it's mimicking an FC receptor, the anti-idiotypic antibody is going to be looks like a rheumatoid factor. And I think that's something that we need to be looking at. But there's so much right now. We're just trying to dig out from underneath the onslaught of this disease, and that's why I call it flag of war, because they're still in the battlefield stage. As we step back and really start doing research on it, I think we're going to discover that it's much more complicated than we thought when we were just looking at SARS.
The only thing that I will say is that based on a clinical kind of approach to diseases, is that what I've often found is that diseases are actually quite simple if you can find where the primary pathology is. What usually happens is that if you don't identify that primary thing, it's difficult to explain all the other associated features. So in my view, I'm pulling us back a little bit to that autoimmune question. When we look at all of the organs that are involved, in terms of the kidney, in terms of the liver, it's not just the lung and even the brain. This has got to be something that's way beyond simply a viral infection. And the only thing that I could find that tied it all together is an immune response that is affecting multiple organs at the same time.
Well, when IgG starts being produced in about 7 to 10 days, that's when a lot of people start having the cytokine storm and other things. So immune complexes, the combination of the viral antigens and the IgG, besides just the viral antigen and ACE2, are going to contribute to the immune response. So those are the things we need to be looking at. You're absolutely right. I mean, this is the point that Bruce and I are trying to make, is that there's a lot of things in the literature which are just more or less assumptions, and they really don't know the molecular mechanisms. And until we understand those, you're absolutely right, we're not really going to have effective treatments. I mean, right now, we're treating the symptoms. There's a cytokine storm, so we use anti-IL-6 or anti-IL-1. But what about, as Bruce pointed out, IL-8? I mean, we need to understand the underlying immunopathology better to be able to have better treatments than just treatments that are essentially very, very elegant biotech, band-aids, but still band-aids.
And one of the questions that I could not quite understand is, why don't we seem to have more autopsies being done? Is there something that we're missing with regards to this?
I think it's just that the healthcare system's overwhelmed at this point, and I think that that's something that Again, I mean, at first, when you've got so many cases like they had in China originally, and then New York had, and others had, I know in the Los Angeles area, they're trying to do autopsies more. But, you have to get, the consent of the family and a lot of other things. They just had the loss or in the middle of a pandemic. There's just, HIPAA laws and things like that that are slowing it down.
Yes.
Yeah, go ahead, Bruce. We'll come back to this question in a minute. Yeah, go ahead.
I had just heard similar. My colleagues in Detroit I've heard similar things, that just being overwhelmed with the number of patients, and in fact, there were some reports in the news of the morgue being backed up and casualties being stored in refrigerated storage rooms until the morgue could free up. There's just the sheer number of casualties made it difficult to get any sort of clinical samples from patients, for example, for research and so on. It's just a sheer numbers problem. Yeah.
So Kanan has asked another question here. Based on what we're saying, if this was an immune response, what stage would you therefore administer immunosuppressants?
Well, I think it depends. It depends, one, on what type of immunosuppressant you're talking about. If you're talking about something that's extremely broad-acting, like corticosteroids, that's really now being frowned upon, even in the later stages of the disease. And so something that's broad-acting is going to have more, it's going to allow the virus to reemerge if it's already on the downward swing. Now, something that's a little bit more precision, like anti-IL-6, then that's something that's a little bit easier to control. So I think it's a question of what immunosuppression you're talking about. You're talking about something broad-acting, which would probably not be a good idea, or something that's much more specific, which we understand much better. And I think that's a better approach.
Yeah.
And certainly after the first week or two, not when the virus is peaking.
Yeah, I think I have a similar view in that you have quite a balance between the immune phase and the inflammatory phase of the disease, and the timing of when to give immunosuppressants is probably going to be quite critical. And I'll quickly mention one of the things is the MATH protocol, which I think that they've been using in Houston. I haven't looked more at the details recently, but their outcomes apparently were quite good with using very high dose ascorbic acid with IV steroids quite early on presentation to accident and emergency. And that's probably something that should be explored a bit further, but it's still a question nobody quite knows the best answer for.
And there's just a paper.
Go ahead.
I'm sorry to interrupt. There's just a paper that came out on the molecular mechanisms of vitamin D, and I didn't get a chance really to review it before this program, but I certainly intend to, and people should really look at that because there's so much misinformation. This drug works, that drug works. Don't take ibuprofen. Oh, take it. And when we start understanding the molecular mechanisms for something, and then it seems to be from a risk to benefit standpoint. I mean, I'm taking vitamin D. I mean, it's like it just for risk to benefit standpoint, that seems to be a really good idea. Famotidine, I take acid reflux medication anyway, so I'm taking famotidine. Now you have to check with your doctor. I don't want to give medical advice, but I'm just saying you have to look at things from a risk to benefit standpoint.
How about fish oil, Neil? Are you taking your daily fish oil?
Yes, I am. And I think that, fish oil is an anti-inflammatory, but I wouldn't call it an immunosuppressant. It's like the antibiotic metronidazole. We know that it modulates the immune system, and we use it in IBD quite a bit, but I wouldn't refer to it as an immunosuppressant. It's just not that strong. So something like that, I think, is a very good idea to try to quiet down, but I doubt very much. I haven't seen any papers that are peer-reviewed that suggest that taking fish oil or something of that nature is going to make COVID-19 worse. And certainly reducing inflammation is a good idea.
Well,
go ahead, Bruce.
There is a huge literature on the benefits of fish oil in a variety of chronic lung injury models, animal models, and lung fibrogenesis models, that fish oil is protective, for whatever that's worth.
Well, it may be relevant because what we're going to be seeing post-COVID is probably quite a significant increase in lung fibrosis for patients who have survived being on an ITU. And so it may be quite relevant for people who have had quite significant lung involvement and they have been discharged, that probably taking fish oil, it certainly won't hurt them. Whether or not it will protect them is another question. But I think that makes a lot of sense. I'm going to raise a question here that has come up. Mutated versions of the virus. And this person is speaking specifically about in the younger individuals. I'm not sure if I've heard much about that in terms of mutations. The only thing I know at the moment is that it seems as though the virulence of the virus seems to be decreasing as time goes on.
I mean, there's the mutation that's been reported in Europe, the D614G mutation, and it's supposed to spread the virus more easily. There's a theory, and I'm not going to say I'm endorsing it, I'm just going to repeat the theory that the virus that went to Europe and then New York is more virulent that went hit the West Coast. And you know, that may or may not be true because of the other factors, you know, again, I mean, what's happening around the world with some of these protests and things, you know, we're not social distancing, and I don't want to get into any of the politics, just from an epidemiological standpoint. I see a lot of people very close to each other without masks, and that worries me tremendously. And so I think it's too early to say that the virus has reduced its virulence, because I think, you know, just like Ebola, you know, you see people, they change their behavior and then the peak goes down, and then if they go back to their old behaviors, then it comes back up. And you know, again, I have a great deal of concern if we're not wearing masks, we're not doing social distancing, if we're not washing frequently, we're not taking those simple precautions, then we may see a resurgence of the virus and find out that it's not decreasing in virulence at all.
Absolutely. Here's a question that I don't know if you want to take on, Bruce, is that in the classical ARDS, the migration of bacteria from the gut to the gut-lung axis has been reported. I don't know much about this. Ed, have you got any kind of understanding of anything like this?
Not in relation to COVID-19. There is a gut-lung axis, and there's some interesting mechanistic relationships between the gut and lung, but I haven't seen any studies related to COVID-19 yet. But that's an interesting theory to keep in mind.
Oh yeah.
And I think that would be something that'd be important if people go from having respiratory signs to GI signs. Again, as in the one person I know that got it, who I was very worried about because he was extremely high risk, he only had GI signs. He never had any cough or anything like that. And in veterinary medicine, canine coronavirus is solely a GI virus. Feline coronavirus starts out as a GI virus, but then in some cats becomes a chronic fatal vasculitis. And that's something else too. The vasculitis and the blood clotting, that's a tremendous problem in COVID-19. And we're just starting to even become aware of it, let alone, you know, have worked out the mechanism. I know another COVID-19 survivor who's fairly young, in his 40s, didn't have any comorbidities, and he recovered okay. His lungs are okay, but he's still having problems with blood clots and some minor neurological problems. But, you know, again, there's a lot more going on with this virus than just the respiratory virus.
Can I make a point here? I've listened to something in the past 2 days. I've found that going back to basic medicine has been quite helpful. And I was listening to the concept of the type 3 hypersensitivity response, which is like the serum sickness. And what seems as though I've not seen anything that so closely matches what could be happening in COVID, certainly in the lungs, where when you have the floating complexes, they do a lot of endothelial damage, which can then cause lots of microthrombi and thrombi in the lungs. And I think this is the thing that I'm saying, is that more and more, when you hit the right mechanism, you can suddenly see how it could cause all kinds of responses, including gut, lung, kidney. simply just by the fact that there is an antibody-antigen reaction, either type 2, which is antibody on cell, or type 3, which is antibody and antigen in the bloodstream?
Well, that's something that, again, I don't think that a lot of people, because I've seen this over the years in biotech, that people haven't understood this. The main activating FC receptor in non-human primates and humans is FcR2a. And the largest pool of that is on platelets. Platelets have about 20,000 FcRa on their surface, but there are 500,000 per microliter. And even though immunocompetent cells will have much more, they may have 200,000 if they're activated, 250,000. There's a lot less mononuclear cells in the bloodstream than there are platelets. So platelet activation, and that's contributing probably to what's happening with the blood clots, is something that's very important, and I haven't seen a lot of research on that. So I think that when you take into, when you're looking at serum sickness and stuff, you got to take into account that pool, the largest activating pool of FC receptors, is on a cell type that people aren't really looking at because they don't really think of it as being an active part of the immune system. And it's extremely active and releasing a lot of, inflammatory substances when platelets become activated. And certainly they cause blood clotting and such, thrombi.
Mm-hmm. Yes, I think that I'm just looking through some of the questions here because we're probably coming towards the end of our time. Some people are interested in quite specific questions, and I'll throw this to you, Bruce, since you mentioned it, is that what dose of fish oil would you recommend?
Well, I'm not a physician and I'm not an expert on the fish oil, but I can tell you that there's a researcher named Richard Baybutt who has published extensively, last name Baybutt, a professor in Chicago at Wheaton College. And he has published extensively. He's a nutritionist, and he's had funding from various nutrition-related sources in his career, and he's published the most on the protective effect of fish oil against a variety of lung injury models in preclinical animal models. Mm-hmm. Rather than tell you a dose, I would refer you to his work. I'm sure if you put his name in PubMed, you'll be able to find his works. I take 500 units a day of fish oil, but there is a large literature on protective effects of fish oil. He has also studied flaxseed oil and other oils as well from a nutritional standpoint on their effects on acute and chronic lung injury models. And in general, the fish oil appears to be protective against bleomycin, for example. Whatever sort of insults you want to throw at a experimental animal's lungs, fish oil appears to protect. So, but I'm not a physician, and I would hesitate to give any dosing information for that reason.
I'm going to throw one last question in here. I'll throw it to you, Bruce. I mean, Neil, if you want to take a look at this. This is probably one of the clearest things that we've seen among the mortality statistics is that men clearly are affected a lot more than women. Any thoughts as to why?
Well, you have to look at, there's a lot of other factors that are involved. Men are more likely to smoke than women. That certainly is a predisposing factor. Hypertension may be higher in men than in women. That's sort of a silent disease that may not be diagnosed as much in women as it is in men. Bruce, you can comment on this. ACE2 expression is higher in men, especially as they get older. And one last comment I'll just make here is when you're talking about immune complexes, one of the things that I found was really interesting, and I'm just going to throw it out as a hypothesis on this autoimmune idea, is that if you look at circulating immune complexes, they don't, even in normal people that don't have autoimmune disease, you can't detect them until about 60 years of age. And then with each decade that you get older, they increase. So older people are already predisposed to having immune complex diseases. And I haven't seen a lot of research, but I would really like to see research on whether autoimmune diseases such as lupus and things like that are predisposing to getting the COVID-19 or not.
Wonderful. Right. Well, I think this has been an absolutely fascinating conversation. And I'd just like to say if we have any last thoughts. So if, starting with you, Bruce, any thoughts that you'd like to put across?
I'm remembering some comments that were made earlier about the possibility of genetic either variants in sequence or polymorphisms in ACE2 as a possible explanation for differences in susceptibility or poor outcome. And here at MSU, we have a computational biologist named Jeremy Prokop, Prokop, and he has done an extensive analysis of the sequence variants in ACE2, which is either published or going to be published very soon. So keep an eye out for this study. But his analysis of all the sequence variants in ACE2 demonstrates that across age, gender, race, and so on, there's no way that the sequence variants in ACE2 could explain differences in susceptibility. So I've seen that notion bantered about in various papers, but if you do the modeling based on what's known sequence information, it can't be explained on the basis of genetic variance across race, gender, age, in terms of ACE sequence variants. So
Yeah.
watch for that paper. But I think as has been said earlier, there's a lot of misinformation out there based on what appear to be presumptions about what some of them very good presumptions, what you would think would be happening. Like, for example, the soluble ACE, since it contains the active site of the enzyme, you would predict that it ought to be active. But so far, what we're seeing when we measure it is that for some reason it's not. Maybe there's some a conformational change that occurs once this extracellular domain gets cleaved. It now assumes a different conformation that renders the enzymatic site inactive. Or maybe when it's floating around out in serum, maybe there's something in the serum that comes in and inhibits the enzyme. Who knows? Something like that. But we need to be careful about what we know versus from data versus what we think is likely to be happening, because we think we understand it without actually measuring things. So
yes, quite true. And Neil, any final thoughts?
Yes, it's a pleasure always to be talking to both of you, but especially you, Bruce. You've devoted your whole life to ACE2, and this is your moment.
Well,
every time that I hear you, I say, well, that's not what the literature says, but you have the experience to back it up, and you're very knowledgeable about the facts. And it's just been a pleasure just today and earlier this week to get a chance to talk to you. Thank you, Philip, for having me on. I really appreciate it. But again, this is what I just will underscore what Bruce said. Science is fact-based. It doesn't matter what people think. In the end, it's just facts. And so as the facts come out and they can be verified by other laboratories, that's really what's going to matter. And again, people like Bruce that have devoted their whole life to ACE2 and know it inside out, those are people that really people should be looking at as a true expert.
Well, thanks for that, Neil. Nice meeting you in the virtual world here. And thanks for the laudatory comments. And I'm happy to help however I can. And thanks, Philip, for having us on. It's been very stimulating. And we'll look forward
Thank you very much
to future communications on this.
Yes. Wonderful. Yeah. And what I'll do is, as I say, thank you to our audience for being there, and maybe we can have another episode like this where we focus on a different area, we'll just keep that space open for us. And you guys don't click off just yet. I'm going to end the broadcast, but I'll say a few words in the studio. Thank you again, everybody, and have a great evening.
Thank you.
Thank you.